Pediatric chemotherapy saves lives by hunting down and destroying rapidly dividing cells in the body. But because the healthy cells lining the inside of a child's mouth also divide quickly, the chemotherapy drugs attack them too, causing severe tissue damage. This condition is known as severe oral mucositis. We are looking at extreme inflammation and deep ulcerations that make chewing, swallowing, and even taking a single sip of water agonizing. When a child cannot eat or drink, doctors are often forced to pivot, shifting their attention from fighting the cancer to managing the immediate survival risks of the side effect itself. To understand the scale of this disruption, we can look at a retrospective study of 200 pediatric cancer patients conducted at a comprehensive cancer center in Amman, Jordan. The patients in this data pool had an average age of 8.5 years old, and all of them were admitted to the hospital specifically to manage severe oral mucositis. By isolating cases serious enough to require hospitalization, researchers can measure how often this specific side effect forces medical teams to alter the very chemotherapy plans they rely on for a cure. The immediate physical impact on the child is extreme pain, frequently requiring intravenous opioid medications just to provide relief. This animated calendar illustrates the massive time burden these severe cases create. Half of the children spent at least 6 days in the hospital, with some stays stretching out to a 21-day maximum. For families already navigating the immense stress of a pediatric cancer diagnosis, an unplanned multi-day hospital admission adds a debilitating layer of logistical and psychological strain. The physical toll extends beyond pain. Open sores in the mouth combined with a chemotherapy-weakened immune system leave the child highly vulnerable to infection. 85% of these hospitalized children had to be placed on antibiotics. Financially, the median total admission cost reached over $2,100. That includes a $1,075 medication cost, with antibiotics alone accounting for nearly $500. Microscopic cellular damage in the mouth directly forces mobilization of hospital beds, nursing care, IV therapies, and substantial financial resources. Out of 200 children, 110 required a modification to their primary chemotherapy plan. Breaking down those alterations, 60% were dose reductions, 38% were treatment delays. In extreme cases, 2%, doctors completely discontinued the treatment. The severity of the pain and the risk of infection forced medical teams to dial back the life-saving protocol they originally prescribed. It is vital to look at what this data actually represents. There is no evidence in this study indicating that mucositis directly lowers a child's overall survival or cure rate. Instead, a treatment delay or a dose reduction is a protective medical decision. Oncologists adjust the plan to shield a vulnerable child from fatal toxicity. Managing these intense side effects is a mandatory component of delivering the cure safely. Caregivers can take proactive dietary measures to protect the mouth lining during treatment, such as introducing soft, moist foods and strictly avoiding acidic items. Families must watch for red flags requiring immediate medical intervention, a refusal to drink fluids, a new fever, or visible signs of dehydration. Anticipating the physical toll of chemotherapy and mitigating these complications early keeps children out of the hospital, controls their pain, and ensures their life-saving treatments stay securely on track.